And on that note, actually, we are going to share a very innovative project that we have been working on. And I would like to invite my colleague, Chris Lewis. Chris is a rehab medicine physician, and he has just completed his informatics fellowship. He has a dual certification and role and faculty in the Department of Rehab Medicine at the University of Washington. Uh, we are choosing this opportunity to present this tool that is being developed very rapidly for primary care folks. Chris is going to talk about a clinical decision making tool guideline for long COVID for the benefit of primary care physicians, which will be embedded in the EMR and hopefully will help to not only serve physicians here at the University of Washington, but nationwide. This is something that is originating here at the University of Washington, but is keenly being awaited by primary care and long COVID physicians around the country. So over to you, Chris.
Thank you so much, Anita. And that's a tough act to follow. I feel like this is my first time in this group, and it's really I can feel it's very impressive, and I can feel how much camaraderie and care there is in this team. So thanks so much for inviting me here, and I'll share my slides. Um, So yeah, this is our epic campaign for long COVID. So I'm going to go through just some of the details for some of the strategies for how we developed this campaign, and with a focus a little bit on informatics, learning health systems, and hopefully there's some strategies that we employed here that folks can find helpful as they're trying to translate what we know in research and what we're learning in research into real clinical practice. Just to start out with a few disclosures, we do have some funding sources for the work we're doing from the Washington Department of Health as well as from Pfizer. And this is our team. So there's a lot of folks involved. And so no one can really perform any of this alone, which is one of the big lessons from clinical informatics and just medicine in general. We're in a big team. And so I work on this project with Anita Chopra and Andrew White, who is, I believe I saw also logged in. So thanks for joining, Andrew. But we've also been working a lot with other members across UW, and our team continues to grow. We have a UW team who's in the IT department and who's helping us build our Epic campaign, as well as multiple students and a project manager on our team. So thanks so much to everybody. A little background on long COVID. I think I'm amongst experts in this, so we don't have to dwell on this. But essentially, we know that the prevalence of long COVID is around 3 to 8% across the United States, and folks who have prior COVID infections can be a lot higher than that. Additionally, a lot of the presenting symptoms, as we know, are fatigue, cognitive dysfunction, dysautonomia. And these can be difficult to evaluate and diagnose and really come to the diagnosis of long COVID. Often the first point of contact for these patients is through their primary care doctor, urgent care, or the emergency room. And the average duration of long COVID symptoms is around 4 months. But we know that a subset of patients really have symptoms a lot longer than that, with 15% of patients who had symptoms at 3 months still having symptoms at 9 months. And we know that there's also a higher utilization of healthcare resources among patients who have long COVID diagnoses, where one study found that there's twice the number of healthcare visits of patients who had a long COVID diagnosis versus control group. So, with all this information, we realized at University of Washington we didn't really have a way to, one, identify the patients who had an acute COVID diagnosis, and two, to try to make sure that we don't lose contact with those people as they are recovering from their infection, as they're potentially developing symptoms afterwards. We wanted to have a way to better capture those patients and not lose them to follow up or just make sure that they stay connected and have access to the resources that they need. So that was really the nidus for for the work that we started. So not there's a lot of different electronic health records out there, and they have a lot of different benefits. We use Epic for both inpatient and outpatient at the University of Washington. And one of the resources that we were advised to pursue for this type of problem is what's called Epic Campaigns, which really allows you to look at patient data that's captured in the electronic health record and leverage that data to help identify, a subset of patients and then provide those patients with different points of contact through whether it's most often their electronic device, but you can really use texting or email or the mobile app to be able to communicate with them. So it's a great way to, if you have a patient population like folks who have an acute COVID diagnosis, it's a great way to really connect with them. And this kind of was the potential solution for our issue, or at least part of it. So how did we go about this? And I wanted to just give a little more background on clinical informatics and my background. And so clinical informatics is, I think of kind of uh, addressing the quintuple aim through the lens of technology and how that technology touches healthcare. And so when I first was learning about clinical informatics, I think maybe I had the idea of myself programming all the time or looking at data. But I think what I learned through the system or through the training was, and this I didn't come up with this breakdown. I think this is what other people have said as well. But most of it is working with other people, and I think that just goes to show how complicated and also how cooperative medicine is. That anytime we're making change, it's really important to get the right team together and all the right stakeholders to really address all of these different areas, whether it's the patient experience, population health, reducing costs, care team well-being, health equity. These are all really, really important. And there's no one person that can really address all of those across the complex medical system. And so most of what we do, and I think I'll talk through some slides of how we did it, we're building the right relationships to get this work done. So again, background on learning health system, won't go into too much of the details here, but essentially, when I'm thinking about these types of implementation science or implementation of technology in healthcare, this is kind of a good playbook to think about it. And really, we're trying to build a system where we can capture data that is captured from our everyday work and really aligns with continuous improvement. So this type of survey and patient tracking can be really helpful to say, okay, we have a patient population who have acute COVID infections and, symptoms after their COVID infection. How can we better track that? And how can we see if those data, as we track our patients, actually is having the effect we think it is? And it's really through this continuous learning, continuous improvement model of a learning health system where we can do that. And so learning health systems really collaborate a lot with clinical informatics because as technology has really become a part of how we, or a tool for how we deliver healthcare, it's hard to make changes in large medical systems without touching the electronic health record. And so, or just a lot of the technology that we use. And so it can be hard to have a sticky solution, a quality improvement solution, if it's not really fully integrated. And so that's really the approach we took with this project was thinking, what can we build? What can we leverage that already exists in our technology? Who can we use who really understands that technology to build a tool that to help our patients and our providers? So a big part of this is really thinking of all the interest groups and stakeholders that we need to bring together. And I think often projects I've been on in the past, have one or two of the groups involved. But I think with these types of implementation science, learning health system endeavors, we really need to find groups who are in all of these different categories and bring them together to be successful. And so that includes operations, research, and the end users like the medical professionals themselves. So our strategy for doing this was really to partner with the existing IT department as well as operational leaders across our hospital system. And so here was just listed a few of the key team members who we were able to, after submitting this as a formal project for our IT department, we were able to get a lot of support from leaders like our Population Health Officer, our Assistant Director for Epic Cogito, Medical Director for Primary Care. All these people, were key parts along the whole process of developing the tool, as well as representing the interests of the people who would be using the tool. Um, Additionally, we wanted to meet with the leaders who really had the power to say, could this go forward or not? So if we were planning for a system-wide implementation, who really holds that decision to be able to say, yeah, let's go for it. Let's see if this helps. So this was, I think, it really helped push this project forward and get it the resources it needed. So what is the actual Epic campaign and how does this work? And so I wanted to go through just some of the details of what we built. So there's two, factors that we think about when triggering our campaign to see if this is the right patient for this solution. So our patients, we wanted them to be in panel patients because if they're interacting with our resources, we wanted to make sure they have a physician to follow up with them. And then we wanted them to be an adult for the study, as well as they had to have a new COVID infection in about 3 or 4 months in the past. And if they had received a survey before, we built in this 120-day cool down period, so they're not just getting, if they're getting multiple COVID infections and they've answered the surveys, we also didn't want to cause any survey fatigue. From the physician's perspective, we want to include physicians as well as APPs, and we ended up going with piloting it in just a few locations. So there's a lot of different primary care clinics around the Seattle region, or the Puget Sound region, and we wanted to really pilot in a smaller group to make sure, one, we weren't going to be overburdening our providers with this new tool, as well as it would give us a chance to make modifications and get feedback before rolling it out more further across the system. And so Shoreline is a neighborhood in Seattle, and we decided that that was a good location to go forward because there was also buy-in from the local leadership. So the way our system works is it involves a 4-question symptom screening questionnaire. And so when a patient gets a acute COVID diagnosis, in that 3 to 4 month window afterwards, they get a screening questionnaire to fill out to see if they still have any symptoms. And so if any of these questions are answered in the affirmative or yes, then their primary care provider, because they're an in-panel patient within UW, would get notification of the survey result as well as educational information on what to do next in their follow-up visit regarding some of the initial workup and resources. And so we'll talk about that a little bit more in a second. But what is our workflow and triggers for the whole process? So as I mentioned, a patient has a COVID positive test, then the campaign is sent to them, um, uh, in that 3 to 4 month window, and then they get another reminder actually within 7 days. And one of the cool features of the Epic campaign was we could really customize the outreach modality based on both the patient preferences as well as if they'd successfully logged into the application or not. So if someone has, for example, the MyChart app, and they're not responding, they could be sent, if they have a text message option, we could then send it to them via text message. And then if again, they're still not responding, we could send it to their text message or even email. So if that was their preferred method, there's an opportunity to do that. And so, like I mentioned, if they respond in the affirmative, their primary care provider would get notified. So this is just kind of another look at, so their primary care provider gets notified. What happens after that? So all of this that we just saw on the last slide is really in this pre-visit. And so the Epic campaign's been initiated. For the first visit, we really envision, and this is kind of a draft because this is a part of it we're still building and finalizing. But there's tools in Epic called Smart Sets that let us really build a lot of different decision support into the process of providing medical care. And so what we can do is based on the symptoms that the patient presents with specifically, we can recommend certain tests or questions that the provider would ask the patient. And then once those tests are prescribed, between visits, the patient would complete the tests. There may be additional services that are recommended, like outpatient therapies, rehab psychology, social work, vocational rehab. And then in the follow-up visit that's scheduled by primary care, they would then go through the results of the testing that was done. And if during that period symptoms have not improved, and with the initial workup, we then wanted to make sure there's an opportunity to escalate care to our long COVID clinic, or provide an e-consult. So campaign context examples. So we were working with, so this is fresh off the press. We've been working with our Epic Campaigns team, and we were just going through some of the examples earlier today. And so wanted to be able to share those with you for what this really looks like on the screens themselves. So this is what the symptom tracker survey looks like for patients here. And this is actually the message that they're receiving in Epic, or when they complete the survey. This is after they submit the survey, what they get. And then from the provider's perspective, they'll see this message in the in basket. It'll be under their patient questionnaires tab. And it will look like this, where it says, the patient has submitted this questionnaire, and our records show that, you've had this, or you were sent this survey. You can then see they were submitted the questionnaire, and then there's the results right there, that there's a couple of yeses that are flagged for review. And then, the follow-up messages, just wanted to show what it looks like on the apps themselves for the patients. So this is what it looks like from the care team when they're getting this. And one of the things we wanted to make sure, and when we were thinking about our patient population, was that we had options for this in Spanish. So we worked with our local translator team, and they were able to translate and affirm all of these communications are in Spanish for our patients. And then this is what the email looks like if that's the preferred modality for the patients. And this is what the texting looks like going to the patient. So it's we're curious to see kind of maybe there's specific response rates based on the different modalities as we pilot this, but we think that there will be some great opportunities to really dial this in and make sure that we're being as clear as possible, and providing the most equitable outreach that we can. So for next steps, we're planning for our initial go live to be in July, when we'll be able to do a socialization campaign to the initial clinic, where we'll go and present, what we're building, or what we've built, how we anticipate they'll be using the tools, and explain kind of the plan going forward. And then we'll also generate promotional materials and socialize this across the university as a whole. So that's a part of just all the Epic campaigns, get some publicity there, so people can be expecting it, and know what that looks like. And then we're also finalizing and building those tools for the primary care providers during the encounter through those smart sets and smart texts. And let's see, I think that's the last slide. I was just checking if there's anything in the chat that I can address, but happy to answer any questions or jump to anything else. I actually can't see folks, so maybe I'll try to um, get that on my
Thank you
screen
so
here.
much, Chris. And I want to give a special shout out to Andrew White. Andrew has joined us, and Andrew has not only served as an advisor and mentor to us, but he's an integral part of this project. Thank you so much, Andrew, for joining today. We appreciate your leadership. Thank you.
So this is a question for maybe all three of you, but how do you envision this supporting primary care physicians who may not be as in tune with long COVID, and kind of supporting them at maybe potentially at institutions that don't have a long COVID dedicated clinic?
Yeah, it's a great question, and I think I'm sure Andrew and Anita have thoughts on this as well. I think that's been an integral part of how we're thinking about building this. Really, our target audience is someone who has no, focus or experience in managing this. And so, as we're building our decision support tools and really trying to prescribe a plan that with some explanation really into the existing workflow that they have. So that's the idea with these smart sets and smart texts is it's really living in their note, and we've actually built vanishing tips are what they're called, and I didn't put any screenshots of that in here, but essentially when the note's signed, you can have this text go away. So it can be right in the note in line with what people are reading and where they're entering the information to give tips and tricks of, for this, patient, based on what these answers are, this is what we recommend, to consider for next steps. So we're trying to build as much as possible for recommendations, but also respecting people's, practice preferences in the notes templates that they like to use or, what they feel comfortable doing. So that's what I think we're really excited to hear for the initial pilot is, what's too much, what's too prescriptive and limiting, and where folks are like, this isn't really how I practice. But at the same time, providing people the education or the resources they need to make decisions.
So the goal of this project is to empower the primary care physicians who are the first point of contact with uh, patients with long COVID. Not only uh, can primary care physicians manage these patients, and also we want to make sure that they are not overwhelmed with paperwork and with having to make those decisions in a 20 to 30-minute visit. So what we are hoping to do is to provide these tools embedded in the EMR. Those who do not have Epic, we will be sharing it open source with folks as well. And what we are hoping to do is that they, through the use of smart sets and smart texts, they can, sort of go through that logic, decision-making logic to manage their patients.
And one of the other substantial benefits of this is hopefully it will allow patients to receive diagnoses with higher certainty faster. I'm not an expert I'm an informaticist and hospitalist and not an expert in long COVID, but one of the things I've learned from Chris and Anita is that patients may go a very long time without a diagnosis, may not understand why they have diffuse and upsetting symptoms. And so even if the decision support tools don't radically change the management, or it's still a challenging diagnosis to manage, by pulling the patient into clinic at the appropriate time frame, really the earliest diagnosable time frame after a positive COVID test, could substantially curtail the window of waiting that a lot of patients have. So that's, I think, a benefit that doesn't really require a lot of expertise on the part of the primary care doctor. It's more that it requires a system that pairs the doctor, the knowledge, and the patient in one spot at the right time.
Go
Um,
ahead, Darlene.
Yeah.
yeah, Chris, hi, this is Darylyn. That was a great presentation. Of course, being a quote wise infectious diseases physician, I dealt with a lot of patients, especially in my area, which is laden with ticks, with post-Lyme myalgic encephalomyelitis chronic fatigue syndrome. And we all knew there was something going on. There was some weird, immunological phenomenon happening with these patients. Many of them, of course, we know were getting dismissed. And unfortunately, some people took advantage of their situation and gave them months to years of intravenous antibiotics, sometimes leading to really bad outcomes. So I really commend you for doing this, for taking the initiative, because these patients really need assistance. And given that many of the long COVID clinics I know have very, very long waiting lists, I love the idea of embedding the e-consult in there and starting sort of the multidisciplinary approach early on. I think it's going to be a win-win for both the patients and for their practitioners. So really a great model. I'll be paying a lot of attention to see the research and the presentations that are going to come out of this. So, are you aware of anybody else on the Epic system doing this anywhere else in the nation?
Anita, I know that you were mentioning talking with someone about some of the things they're building, but I think not to this,
No.
not necessarily an Epic campaign level. Um,
So we have, because we interact directly with the AHRQ mentees, the grantee sites. So we come in contact with all the long COVID clinics. So as far as we know, until now, no one has done this, sort of uh, this effort to embed in the EMR, and also, uh, our approach to diagnose early as well as to, treat is novel in terms of providing these tools to primary care physicians.
That's great. No, that's great to hear. And I just want to just put a little plug in here. Having just gotten my second COVID vaccine, since I am in that age risk group now, I am finding that I am talking, people are like, what do you mean that, if I'm 65 or older, I'm supposed to be getting two COVID vaccines? My doctor, my NP, my whatever didn't tell me that. So there might be an opportunity to remind people about
mm,
appropriate immunizations, et cetera, in your smart set as well.
yeah, that's a good remind. Yeah, that's a great idea. Um, we should add that in.
So I think I will invite Nick next to help us close today's group. Nick, please go ahead.
Sure. So as we wind down, if folks have any questions, feel free to put them in the chat. But Dr. Chopra just asked me to say a couple words on kind of what the being part of this group has meant to me, and kind of interacting with the ACP through this group. And I think number one, it's helped me a ton in my leadership skills, and I think that has been evident as this has gone on for multiple years. I think the other thing is medical school at first feels very small, feels very local, feels very institutional. It's your class, it's your mentors, and I think that this group and other parts of the ACP have helped me really kind of expand that and see that there are really wonderful people doing work all over, and that comes from improving patient care through education. It comes from collaborating with other folks on scholarly work. Like we've done a curriculum to help educate medical students on long COVID with some folks, um, different folks around the country. And I think ultimately it just shows you how physicians build the networks that they have, and how it really translates to better patient care. And so it's been a wonderful experience for me. And so I just wanted to thank Dr. Chopra and ultimately everyone who attends these meetings and keeps the interest and the excitement about learning about long COVID going. So um, thank you all. And with that, unless we have any other questions, I think we can go ahead and wrap things up a little early.
Thank you, Nick. And this recording will be available on our website, and our video link. Nick will share that out with folks. Thank you very much, everyone, for attending, and a very special thanks to Darlene. Thank you for making this so special for us. We will always remember this episode as the highlight of our interest group. Thank you. And thank you for helping, create this group, supporting it and inspiring us. And we've been going on for 2 years now. So thank you very much.
That's wonderful. Well, thank you so very much for inviting me this evening and wonderful remarks. I wish I recorded it for my family. And just to thank you for all that you're doing. A reminder that calls for ACP national committees and councils will come out at the end of the Board of Governors meeting this fall. And so, of course, Nick, we have a council of student members, which you might be interested in potentially applying for. I always recommend that people get engaged at the chapter level. It helps to build their application for applying for a national council or committee. But I urge you all to sort of take a look at what's available and speak with your very energetic governor potentially about your interests. So thank you again.
Thank you so much. And we hope to come back next time with another wonderful session. One of our potential future speakers is here, Dr. Jason Goldman, who we are hoping will talk about research in long COVID. And we are in the process of setting up a session with him. So I'm very excited about that. Thank you very much, everyone. And thank you for making this such a wonderful celebration for Darren. Thank you.
Thank you.
Thanks. Thanks for inviting me, Anita.
Thank you.